All right, good morning. My name is Jennifer. I'm with the Oregon Health Authority. We are going to give you an overview of federal and state updates for school Medicaid. And just introduce ourselves real quick. Again, Jennifer Smith. I'm an operations and policy analyst at the Oregon Health Authority. That's the state Medicaid agency. And I'm currently covering school Medicaid or school-based health services, whichever term you're used to. And Jennifer.
My name is Jennifer Dundon, and I'm a school Medicaid operations and policy analyst at the Oregon Department of Education, which is our state education agency. If you want to go to the next slide, I can get into the overview of today. So today we'll discuss housekeeping for the webinar and then provide a brief overview of school Medicaid. We'll then move into some federal and state updates, discuss our school Medicaid advisory committee, share information and provide an opportunity for feedback about a federal technical assistance grant that OHA is applying for, and then hold space for Q&A. So you want to go to the next slide. So we will pause for questions at the end of each section, and we will do our very best to answer all of your questions. However, there may be some that we won't be able to answer right away. We will make sure we get any follow-up responses sent out along with the presentation. Please feel free to raise your hand with any questions. You are also welcome to put them in the chat. And as I said, we'll hold space at the end for additional Q&A. And with that, I will turn things back over to the other Jennifer.
All right, thank you. Okay, so an intro to Medicaid in schools. School-based health services, that's the program that it's called at Medicaid, but a lot of people refer to it as school Medicaid. So Medicaid is a state and federal partnership that funds health-related services for anyone that is enrolled in Medicaid. So the school-based health services program is part of the Health Systems Division within the Oregon Health Authority. And the Oregon Health Authority, OHA, is Oregon's state Medicaid agency. So every state has a state plan. The Social Security Act establishes Medicaid, and every state must have a Medicaid program. And each state's state plan identifies how that state is going to comply with the Social Security Act. So that's what Oregon's Medicaid state plan is. We'll discuss that. So felt like it was good to let you know how that works. So school Medicaid. There are two different Medicaid billing programs for school Medicaid. The first one is school-based health services, and that's Medicaid billing for health-related services. And then the second one is Medicaid administrative claiming. So the SBHS, school Medicaid, is direct services that are happening in the schools. Currently, the health-related services that can be billed through SBHS are services that are under the Individuals with Disabilities Education Act, and they're included in a student's individualized education program or individualized family service plan. We are looking to add Section 504 plans soon, so stay tuned on that. And then we also have Medicaid administrative claiming, so and referred to as MAC. MAC is reimbursement for activities that are related to the administration of Medicaid. So that includes such things as referrals, application assistance, care coordination of Medicaid services in the community. And a few federal updates for you. May 2023, we have updated guidance that was released by CMS. That's the Centers for Medicare and Medicaid Services. The intent of the guidance was to help states add flexibilities that would reduce administrative burden and increase billing, including adding education-only licensed providers. OHA with ODE support is looking to add school providers licensed only by the Teacher Standards and Practices Commission. More info and opportunities for engagement are coming soon on that as well. Okay, so continuing really on this updated guidance from CMS, it affirms the free care policy reversal. So free care only allowed federal reimbursement for no-cost services on an IEP or IFSP that are provided to Medicaid enrolled children. And this policy was reversed, and the updated guidance confirms that. So, excuse me, the guidance also provides for states to allow billing beyond IDEA. So this may include billing for Section 504 plans and preventive services that are happening in school settings. All of these services must be provided by medically qualified staff. And we will go over Oregon's recently approved state plan amendment, or SPA, and the implementation process that we're going through in Oregon.
So we'll pause here. If anybody has any questions about these federal updates, we're happy to take them. Oh, we got one. Senator Wyden's office recently mentioned the increase in mental health services and formal communication to all districts. Do you have a timeline on the addition of mental health services to the state plan?
So the addition of behavioral health services is part of the new state plan that's been recently approved with our state plan amendment. What we're working on is implementation of all of the things. That's the first step to have approval to be able to provide those things, to be able to allow schools to bill Medicaid for those things. So that's our first step. And now we're working on implementing all of the things that are in the state plan, beginning with the 504 services.
And you have, in order to make this happen, I think the administrative rules need to be updated, and you do have a timeline for that. Would you be able to share that information, Jennifer?
Yes, absolutely. We'll be sharing that a little bit later in the slides here.
Okay, and I see a hand up from Karen.
Yes, you indicated that it was licensed providers, and I'm curious about that because I had understood that also like QMHAs could provide skills training in the schools, and that was also billable as a Medicaid service.
Are you referring to the TSPC licensed only?
Don't know.
Okay, so we have basically the Oregon administrative rules allow certain provider types to provide services in school settings, billable services. Let me make that distinction. It's not that they're not providing services, but what is and is not billable is written into our Oregon administrative rules. So behavioral health services are allowed per our newly approved state plan amendment and written into the state plan. But those Oregon administrative rule changes need to happen in order for us to create that pathway to Medicaid billing for more services than are currently billable.
So are you saying that they're not currently billable?
I would have to review the rules, and I'm happy to do that and see which ones are currently billable.
Okay, thank you.
Mm-hmm.
Okay, and so there's another question in the chat. Are TSPC licensed school counselors included in being able to bill?
Currently, they are not.
But they are included in the list of practitioners that are TSPC only licensed that OHA is seeking to have approved, correct? School
Correct.
psychologists, school counselors, and school social workers are all three. Work is being done to add all three of those.
Yes, absolutely.
Okay. There's another question. How does this impact school-based health centers, which include behavioral health?
It shouldn't impact school-based health centers. That's a separate set of rules. They're like clinics on school sites. Most of them are sponsored by federally qualified health centers. So they're following a different set of rules that is set in place for clinics and health centers. And it's a totally separate entity. So the school-based health services is very specifically the services that schools are providing in support of a child's education. So it's completely separate from school-based health centers. I hope that's a helpful answer.
Okay, and then we have a question. Would someone BCBA certified be able to bill for that service for students with ASD?
ASD.
Autism spectrum disorder.
Okay. So again, I would have to review the rules. Full disclosure, I've been working on the school program for about a month. I meant to say that when I introduced myself. I am very familiar with the program, so I don't want that to scare anyone. But I worked on the program about 4 or 5 years ago, and I'm coming back into it and have been back into it for a month. So I need a refresh on the rules, and I will review the rules and make sure of that. I know that we do enroll BCBAs. We enroll applied behavioral analysis providers, and I would like to see them be able to bill in the school setting, but I need to review rules and the state plan and make sure that we can allow that. So I don't want to say yes to that yet.
Well, I can answer that they are not currently billable, and neither
Okay.
are QMHPs. Neither of those two are currently billable for mental and behavioral health services.
Okay. Thank you.
And then we have a question, will we be sharing the slides? Yes.
Yes, we will.
Okay.
Okay. Anything else for now? Are we ready to move on? Okay, so I will talk about the referring provider requirements. This is definitely a hot item right now. So our school-based health services, we had a claim finding in the payment error rate measurement audit of OHA, and we entered into conversations with CMS about how to remedy that finding. And they indicated that future claims for school-based health services must include an ordering or referring provider. So per our conversations, we're meeting this requirement with the referring provider. So by June 1st, all medically qualified staff that are providing services in schools will need to enroll with the Oregon Health Plan, OHP. And that involves getting a national provider identifier for each staff member and completing the enrollment process with OHP. So where we are currently with this is system setup for this change is being finalized. Lots of work going on in the background, system being the Medicaid Management Information System, or MMIS. And we're also in the process, as we're making those changes in MMIS, of creating guidance so that school providers can, first of all, find out if medically qualified staff are already enrolled in OHP. It's a possibility. And then if a staff member is not, then that guidance is also going to show you how to enroll each staff member that's not already enrolled. And I will say that schools may be completing this process on behalf of their medically qualified staff, but medically qualified staff could also complete this process. It just depends on how you'd like to proceed with that. And I do want to stop again and make sure there's no questions on this piece.
We have one in the chat.
Okay.
Are you looking at the ability to enroll all individuals in a mass upload?
I don't think we have the capability to do something like that. It has to do with which specific forms are required for each individual. So it's a one-by-one basis, but there are two different options for enrollment. And again, the guidance is going to state this. The forms are the same, but we have either kind of a paper process, I guess, where you fill out the forms and you fax them over to our team, or we also have a web process. So more information on that again soon, but there's a web process where you go into the provider web portal and you enter some information and you just upload. It's the same documents, but you can upload them in that web process for each medically qualified staff. And then our enrollment team works on making sure that they're all enrolled fairly quickly.
Another question.
Okay.
When will this guidance be released, and how will schools be able to enroll for staff when it will ask for a social security number and such to get an NPI?
Okay, so the social security number requirement is at the federal level. It's something that we have to do. I don't recall all the details about that, but it is required for individuals enrolling with Medicaid. So again, the individual can do the enrollment process on their own, or the school district can do it on their behalf. But some of the requirements are that national provider identifier, or NPI, and also a social security number on the application.
Okay, and then a question from Chelsea, fairly new to
Okay.
this. Is there a list somewhere of what types of staff under current rules are approved for Medicaid billing? And yes, and I can put a link to that in the chat in the next little bit here.
Great.
And
Thank you.
then from Joe, the enrollment and credentialing team is currently 3 months behind. Is this a concern for these rules?
My enrollment team, the OHP enrollment team, is behind. This is something that I am working directly with the manager and lead worker of that team on to expedite school Medicaid enrollments. So I'm hoping that we won't be 3 months behind by the time you get that in there, but we're working in the background, so it shouldn't be a 3-month wait.
Sorry, and maybe you said this, but I didn't catch it. So there's another request for, do you have an idea of when this guidance will be released?
Oh, you did ask that. Yes, and I was answering other things. So I am hoping that the guidance will be released in the next week or so. We have it fairly finalized, and we need to go through our avenues at OHA to make sure that we can go ahead and post it. And I will make sure that that information gets posted, first of all, and that we also send out an announcement that this has happened. So you'll know it's out there.
Okay. And then this question, will they be able to provide service until the registration is finalized?
Oh, of course, this is strictly for billing. This is your pathway to payment for school Medicaid. So whatever services are happening, please continue to, of course, you're going to continue to provide those services. This is just the pathway to payment. And this is an effective date of June 1st. So what will happen is, regardless of the date of service, any claim that you're submitting on or after June 1st has to have that referring provider ID included, or it will deny for the referring provider. So please continue. Of course, you're going to continue to provide the services, and you're going to continue to bill. Just know that every claim will require it as of June 1st.
Okay, and then is there a resource to confirm a provider's enrollment with OHP?
There is, and that will be in the guidance. There's a couple of different options. It's really whatever works best for you. So I was talking with our enrollment team. Our provider services unit, if you were to send them like a spreadsheet or a table or whatever works for you, a list basically of NPIs, they can look at each NPI and let you know if they're enrolled. However, if you don't want to go through that process, you don't want to wait for provider services, really just whatever works for you, there is another way to check for it on the provider web portal, and that will be in the guidance coming out pretty quickly. And it's going to be step by step. We're going to include like screenshots of what to look at. So it should be a pretty easy process if you'd like to do it one by one at your office.
Okay, and then we have another question. Will LPNs need to be referring providers if RNs are signing their logs for billing submission?
No, you will have the RN enrolled.
Okay, I think that's it.
Okay,
All right.
fantastic. All right, so a few more state updates. Here's our state implementation timeline. So I think the real important stuff on here, of course, go ahead and review, is Oregon administrative rules. The state plan amendment was approved. So we have the services in the state plan that we'd like to make a pathway for payment for Medicaid enrolled children. So our Oregon administrative rules need to be changed in order to align with that state plan amendment. So we are currently working on the rules, and we are hoping to adopt in July. So February, that's the bottom orange one there. February through July, we're working on Oregon administrative rules. And then, of course, guidance and documents and forms that'll all come later from the OHA side, anything that needs to align with the state plan. And then we are going to provide presentations and trainings during the month of August, and of course forward as needed. And we're hoping to implement at least the addition of Section 504 plans by September of 2024, and the additional providers hopefully as well. All right. So key updates in the approved state plan amendment. It increases the types of billable services, the types of medically qualified staff that can provide billable services. It adds Section 504 plans and any other documented individualized health or behavioral health plans as otherwise determined medically necessary for services that are provided in school programs and settings. So OHA is taking a phased approach to implementation, and we are beginning with the Section 504 plans. It also adds the potential for free care. And then just a state plan comparison here. We have on the left, the previous state plan, which included health-related services required by IDEA, specified on a child's IEP or IFSP, and provided by a set of approved providers, your medically qualified staff.
And just to pause, I wanted to pause here because somebody had asked about a list. And so on the left is the list of the currently billable practitioners. On the right is the types of services that are included in the state plan. And so what the work that's going to be done is to add to that list on the left. So the left is what rules are currently allowing. On the right is more broad, right? So there's service types, and within those service types, there are multiple practitioners that would be able to provide those services. So what we're working to try to do is add to the list on the left, but it's not so simple because they still have to meet certain requirements from the federal government and things like that. So,
right.
Yes.
Great. Thank you for that distinction, Jennifer.
Oh,
So the
right,
20, go ahead.
We have a question.
Okay.
We've got one from Charles. What does the potential for free care mean?
So with the policy reversal that was confirmed in the updated guidance, we're hoping to be able to add more services to that. So free care is, and Jennifer, can you give a better explanation of free care than I do?
Well, I will make a note that CMS even said that they probably should come up with a better definition for it.
Right.
So, but the way it's kind of been explained as is there's services provided pursuant to IDEA, services provided pursuant to Section 504, and then there's free care, which would be like screenings, evaluations, things like that, more like services provided to the general population, things like that. So that's a little more tricky to map out, which I believe is why OHA made the decision to start with the 504 plans and additional practitioners, and then figure out the additional pieces that may be billable.
Right. Thank you for that. And then did we have another question?
It was, but she said never mind, because she was asking about personal care services, which are included in the updated state plan.
Okay, great.
Okay, and now we do have a question. We got two. We got a hand up and one in the chat. So
all right,
Kelly, you can go, and then I'll do the one in the chat.
Sorry, this is just in follow up to the how you explained the free care, which was great. Thank you. So this is the intention or the hope then is to move this out of IDEA and 504 only, and to potentially, like, am I understanding that correctly, that then screenings or those kinds of things that might occur in a like population wide in a school could be also covered? Is that where the intention is to hopefully head, but starting with low hanging fruit first?
That's how I understand it. And so yes, the state plan is approved for those things. The mapping out of them and the rules and things around it would be the piece that would have to get sorted out.
Right. Thank you. That helps.
Yeah. And then a question from Cherie. What will be the necessary documentation for billing 504?
So the necessary documentation is obviously there's a 504 plan in place. You're going to have the services that are being provided. It's similar to how it is on IEP or IFSP, how we use those as the prescriptive document. And when you have a medically qualified staff member providing a service, a health-related service to a child, then they're keeping notes according to their licensing board rules as well. So that's the documentation that I'm more familiar with as the Medicaid agency. So you do have to have medically qualified staff have to document their services as they would if they were working in the community. But then the 504 is would be the prescriptive document, just like the IEP and IFSP are now. Jennifer, do you have anything to add to that?
I do.
Okay.
So Section 504 plans are written a little bit differently. So this is some of the areas where training would be required and guidance from the state on exactly all of the elements that are required to do this, because you're still going to need frequency, duration, location. That's a requirement from the federal government. You still need parent consent. You still need a written recommendation. Like Jennifer said, you still need the documentation provided by the medically qualified staff. So a lot of it is similar. We're just going to be bumping into the fact that IEPs and 504 plans are not written the same. So if that's helpful.
Okay.
This is Sheree in relation to that question. The problem, Jennifer, a lot of times when you do the 504, the placement, you may do that on the 504 plan, but the outplacement and the services are not always provided by a licensed person. So that's my concern.
Well, and also if the information isn't in the 504 plan, the plan of care is going to be really incredibly important as far as to document why the plan is in place. So, and if people are providing the service that aren't medically qualified, they may or may not be billable depending on what the services that they're providing. Like delegated healthcare would still be billable. When we look into personal care services, that may or may not be provided by somebody that is medically licensed. So these are the big pieces that we will need to map out and hope to engage people like yourself and others that can help us ensure that we're implementing things properly.
This was a concern at the federal level when I was regulating some of this at the feds and depicting what exactly documentation when you do a 504. A lot of the individuals are people that are assisting a licensed person, maybe at any one given time. So it'll be interesting to see what documentation you guys come up with and how we're going to process this. Thanks.
Did I hear that you would like to volunteer? Did I?
Let's go, Cherie, engagement.
Yes. Okay, I heard consent from parents be removed. Is this still a plan? Okay, so when this guidance was released, this federal guidance was released in May 2023. The U.S. Department of Education also released information that they were going to propose an update to the rule in the IDEA that required the certain elements for parent consent. They put the proposed rule out there, received public comment. Haven't heard yet whether or not that is going to, they're going to update the rule, but I will note that even if the rule does update what's in the IDEA, it isn't going to change the privacy requirements under FERPA. So there's still going to have to be, it's basically, it will change a little bit, but not everything. There's still going to be requirements to notify when information is going to be disclosed and obtain permission. So, yes, I did hear they haven't released any information saying for sure we're not doing this or we are, but I did also hear, Cherie, that there was a lot of pushback at the federal level from advocates that were opposed to having that information taken out of the IDEA.
I can advocate with AASA and ASBO to see if they can legislate at the DC when they have their conference to see if they can push to do more a different level of removing the parent, which sometimes is a barrier.
I'm not seeing any more questions. Jennifer, if you want to.
Okay, so let's go ahead and keep going with state updates. So Oregon administrative rules, I know we showed you the timeline. We are updating them to bill for the expanded services per the updated state plan. So we're in the process of updating, and here's just a quick little timeline specifically for Oregon administrative rules without all the other stuff. So we are hoping to finalize the language by April 1st. Our expected date to adopt the OARs is July 1st. And of course, it's not just a linear process. So training and up on the updated rules, we're hoping to be able to provide in August, and of course, ongoing as needed. And Jennifer, would you like to
Yeah.
talk about the advisory committee?
Sure, if you want to go to the next slide. So a school Medicaid, we did have a school Medicaid advisory back in 2019 to provide direction and guidance for our school Medicaid pilot project. The committee was comprised of members representing a variety of perspectives and served as an informal advisory body as we worked through the implementation of the pilot project and subsequent report. The committee was disbanded after the pilot project ended, which also happened to coincide with the pandemic. Due to all of the state and federal changes happening in the realm of school Medicaid in Oregon, ODE and OHA decided to bring back the committee to support the implementation of these changes with the following goals: maximizing school Medicaid billing in Oregon, removing barriers to participation, developing and updating training and resources, increasing the number of participating school districts, and continuous program improvement. And you can see, I'm not going to read the slide because that's not fun for anyone, but that's a list there of the membership that we are seeking. Jennifer, if you want to do the next slide. So our timeline, we expect to solicit applications in March 2024, and then ODE and OHA will jointly review applicants and determine membership. Announcements of membership will be made in mid-April, and we hope to hold our first meeting in June. We plan to meet every other month for the first 6 months and then at least quarterly thereafter. So I'll pause there for any questions.
Are you gonna do this via Zoom?
Yes, the plan is to hold all meetings virtually. So if you'd like to come back to our advisory committee, Cherie, that would be wonderful.
We'd love to have
You're
you.
so funny, Jennifer. I have a feeling you've already appointed me anyways.
Yeah, see, you just got another nomination in the chat, Cherie. So just looking. All right, I think
Right.
that's it
Moving
from
on.
my spiel there. Yes.
All right. So we have a grant opportunity that I'll talk about next. And there's a lot of words on this slide. But OHA with OD support will apply for this grant. It's a CMS grant for implementation, enhancement, and expansion of Medicaid and CHIP school-based services. And the grant funds must be used to support infrastructure development in one of 3 categories. So those 3 categories are implementation, expansion, or enhancement. And lots of things could fall under all 3 of those things.
Okay, I'm
So
gonna
that
pause.
being,
I got a question from Cherie in the chat. Is this the new House bill? They did propose a House bill that would have had a 22-member advisory committee with governor appointed staff for 4-year terms. But in talking with us and hearing that we already kind of had something like this in the works that would achieve the same kind of goals, they removed that from that bill. And now we're just doing it like this. I had to present to the House Education Committee about it. So.
All right, I'm going to go ahead to the next slide. So engagement and timeline for the CMS grant, it's quick turnaround. The notice of funding opportunity between that and the application being due is a very short timeline. So we are seeking input though from local education agencies, how to best use these funds to meet the intended purpose and goals, but also to meet your needs in the community. So the goal is supporting efforts to bolster state and local infrastructure for providing, billing, and claiming of school-based health services programs. The purpose, grant funds are for the purpose of implementing, enhancing, or expanding the provision of assistance through school-based entities under Medicaid and CHIP. So we have a survey that's available right now. We would love your input. We've kind of organized things so you can choose what you think is the most helpful. And then also there's some open-ended questions on there that you can fill out. So our timeline, we are submitting a letter of intent to apply on February 23rd. The applications are due on March 25th. And then the anticipated notice of award is July 1st of 2024. So please do let us know what you think. Take that survey. And then we'll move on to questions
a
and
question.
answers, of course.
Hey, in the CMS, the grant that you're applying, the biggest question around schools is the ability, the fact that staff have workload issues and that most of us don't have a billing clerk. So in this grant, would it allow for the ability to have two kind of people, one that's going to do the administration of billing, do the implementation of the fiscal stuff and integration, create the billing codes and all that stuff, but then have the ability to have a staff member that integrates with the school-based health ancillary service providers so they can help integrate that process. Would it have the ability for funding those type of FTEs? Because most schools cannot fund that.
So the opportunity is there with the grant funding. Of course, we're going to have to look at all the responses that come in and see what we can afford with the grant money. And I know one of my biggest concerns with, it's an opportunity, but how long would that last? And figuring out how to make that sustainable is something that we'd have to look into as well. So yes, it's an opportunity.
I mean, I've built a revenue model for the state of California. It is sustainable.
Okay.
It needs about at least a 2 to 3 year development time
Mhm.
because it takes that much to develop a process. How long is the grant period for this grant that you have?
The grant period is 3 years.
Okay. All right. Thank you.
Yep, for sure.
And I think okay, I've got more questions here. We've got, okay. What is the commitment for grant participation is one.
And we're not there yet. We're still in the information gathering portion and wondering what would be best. Not wondering, we understand the program, but wanting to hear from you what would be the best pathway, what you feel like in schools is the best pathway for us to use this grant funding. We want to make sure it's helpful for the program.
And then somebody would like you to go back a slide. Let's see. Okay, and here's a good question. Is there, Jeanette, were you wanting to follow up on your comment? Is that what you're?
Yeah, if that's okay.
Yeah.
I think my question was misunderstood because I'm part of also the school nurse pilot program grant, which in order to participate in that grant is a lot of work involved. And that is a workload issue. So I think that's where I'm coming from and asking what that time commitment is in order to receive the grant. What kind of reporting are you thinking you're looking for from districts in order to participate?
So I know that we would be required as the state Medicaid agency, if awarded, to do quarterly reporting and to attend meetings. I think it's on a monthly basis. So there's a lot of background work on the OHA side as the grantee if we're awarded. But I don't anticipate that we would be asking districts to report. I think that would be more, I don't anticipate, I'm not saying it's not going to happen, but it depends kind of on the pathway we take. So right now we're still in the, what pathway are we going to take? How are we going to use these funds? But I think that most of the reporting can be from data systems within OHA and ODE. Primarily OHA, I'm thinking, because the purpose is to increase billing, work on the infrastructure, enhance, implement, get it going. And we are going to be able to show from our data at OHA the increased billing, what types of services we're seeing being billed, those kinds of things from our data warehouse. So I don't anticipate that, I guess, is the short answer.
Okay, and then we have a couple of questions all stemming around the possibility for permission to be given back to ESDs to support districts in their Medicaid billing as was done in the past.
I think, just from my history, you would have to go back to the OAR, which is where the DOJ made the clarification that didn't allow the ESDs to do that. If there was a change in the OAR that allowed for that change, which that's not hard to do, you just have to work with them. I think that piece capability could be possible. I don't think the link is in the audit process was the failure of the audit in the feds. It was the clarification of how we worded in the legislation in the laws. Unless there's something that I'm not aware of.
No, that's how I remember. I was right before I started at ODE, but that's what I remember is there was a rule, a Medicaid, one of the school-based health services rules that made it not allowable, and it just got caught during the pilot project. So I would say that this is an opportunity to revisit the rules. They have to all be updated anyways. So it's something that I would assume could potentially be looked into with no promise of anything, but it's certainly worth looking at. Jennifer, I don't know if you have anything to add on that.
I
No,
think
I
it's a
agree.
necessary change because the way for districts to get and leverage the Medicaid billing, because they don't have the bandwidth, is, and it was successful, is to give that capability back to ESDs. It is a function that has worked and did work for many years.
And then I'm also seeing a comment in the chat about some districts would like to do it on their own, so they would like to hope to make sure that districts are represented in any kind of funding that went out as well. So there's that. There's more. Let's see. Let's see. Do you have the grant application? Yes, it's a long read, Cherie, but I can put it in the chat here. Seconds.
Come on, Jennifer, you know I read federal regulations for fun. Come on, this is exciting.
Okay, I'll find the link for you. That's funny. And then let's see, we've got more. Okay, and the OARs in the chat as well. OARs. Novo. And then interested in how they compare to the mental health outpatient rules. Okay. Okay, Charles has a question. Would they also consider eliminating the requirement for LEA providing the match?
Not unless people start paying bills. That's the reason why they did the match.
Yeah, it has to be a government entity that, I know it has to be a government entity that provides the match. And it's what's referred to as a leveraging program where we're pulling down the federal share. And once that state share is there, we're giving it back. So I don't foresee that changing.
Okay, we've got one comment here, questions. I work for the local community mental health provider. When I think of all the compliance and billing parts related to Medicaid billing, it seems like it would be efficient for school districts to contract with CMHPs to provide the mental health services, being as CMHPs already have all the parts set up. Is this relationship possible? I assume that the service providers would need licenses to have licenses with TSPC. Am I way off base?
So I think that partnering is always an opportunity. So I'm going to say that it's just at the OHA level, we're creating pathways. We're creating pathways to payment for services that are already happening. So of course, partnerships are always an opportunity if the school district wishes to take that path. So again, we're creating the pathways. We're hoping to add the TSPC only licensed providers as providers that can provide services, and those can be billed. But yeah, I would always encourage partnerships in the community. I think that's a great thing, but up to the school district on how they want to do business. So.
And to add to that, so yes, some districts do contract with outside agencies to provide medically qualified staff for services in their schools because they don't have access to them. In order to bill Medicaid, the practitioners that you have would need to be under school-based health services rules considered medically qualified. And they would not need the additional TSPC overlay to be providing those services in the school setting. So if that's helpful too. Like if you had LCSWs that were providing services to a school district, those would be billable services and they wouldn't need to have any kind of TSPC license or certification. Okay, but more questions? Okay, can you discuss the rules change that allowed ESDs to bill for Medicaid in 2018? According to the Medicaid billing manual, now it sounds like it was rolled back during the pilot project. So I wonder if Eli is on this Zoom because it's what's
Because I cannot.
there he is. Eli, do you want to give a chat about this? I see you.
Hello, everyone. Eli Sanders, ODE. I do school health services now. I'm trying to step away from Medicaid and keeps pulling it back. Cherie was, I think, correct in what she's mentioned. What happened was either right before the pilot or during the pilot, at looking at supporting districts, we became aware of an issue that OHA, OARs point to those districts who are responsible for providing IDEA. IDEA can only be provided, the FAPE responsibility for IDEA determined by DOJ can only reside in the school district. And so we had a situation, and we took this all up to Department of Justice to try and figure out how to kind of sort it out and make any clarity that we could stand on as far as who can bill Medicaid for school health services. And at that time, and currently, it's all directly related to IDEA. Those who are responsible, that responsibility lies with school districts and cannot be given away. And there's OAR points to that responsibility. That responsibility is determined by our rules. It says the state superintendent of education will, determines, and only school districts fit that category. And so ESDs can support, they can provide billing, they can like MESD provides ORMED, like they can provide a lot of infrastructure support, but the actual billing and where the money goes to, where the match comes from and where the money goes to was determined that it has to be the school district. And so it shifted things at that point. whether that changes or not. I'm not in Medicaid anymore, but as that I can see there may be some opportunity for change. And as Cherie discussed was looking at the OAR as how those providers are determined. Yeah, I don't know if that makes more sense or confuses things more, but it really pointed back to who's responsible for providing that service and who can put the match up and collect those funds. And as it opens up to 504 and other health services beyond IEPs, does that change? I think that's, and free care, that's where we need to focus or look at answers. I don't know. Does that help?
I think the best thing to say is, could it change? At the time the pilot was done, we were doing the pilot, and when we wrote the manuals, ESDs was doing majority of the billing for educational service districts for, let's say, one-on-one nurses, a lot of the STs and stuff like that. So they were doing the billing. However, the ESDs were getting the remittance advice, depositing the cash, doing the reconciliation, then sending the funds back to the school. Well, you can't do that for the legislation. So now the schools have to be able to receive the cash directly. That makes reconciliations the pickle in the room. So it doesn't mean that you cannot contract for them to do something, but you have to change the wording in your contract of how you have to do the process. And there has to be basically the intermediary between the two of you who's actually doing the reconciliation, and you have to pay the match, not the ESDs. So there is the fiscal legislation part of it that you have to get your hands around. But I think in a contract you can, but there needs to be some change in the OARs to allow us to go back to the way we used to do it.
Joe, you have a question?
Yeah, this is a super intriguing conversation, and thank you, Cherie. That's sort of what I was thinking, and you voicing it out loud was helpful. I mean, really, as it stands, though, it still seems like there is a contract fix between the ESDs and their associated school districts that would look, from the medical standpoint, a lot like a business agreement with a third-party billing agency to sort of like manage that, provided that funding structures originated from the LEA, because they would have to do that. Effectively, what you'd have is a staff member at the ESDs who rotated through school districts running their individual sort of like processes, which is a bit of a backflip. Like, it'd be a heck of a lot easier if the OAR just like cleared it up. But that does seem actually like a huge administrative fix for school districts, especially the little ones that I've been working with, like smaller school districts. A whole nother staff member, especially with the training and knowledge and expertise that are needed for these processes, is well beyond what is achievable.
I mean, agree. It is a process. When I was at PPS, we had a contract with MESD to do our billing for something, but I paid the prepaid, the remittance came to me, and then I paid MESD the bill for processing the claims based on how many claims they process. It is something that is doable. It would make it a whole lot easier. But in my world, being the anal accountant is, in my world, it made it, I didn't have control over something, right? And in my internal control processes, that's where, in anybody's that the accountants or the business managers on here, you give yourself up and let them do everything, but then fiscally you're responsible. So where the audit process and the legislation, since Medicaid is one of the top 5 audited programs in the world, a lot of people didn't want to take on that risk. So.
Okay, and we do have another question. Could the CMS grant be used to help develop billing infrastructure that is unique to school-based providers and that would bridge between MMIS and district software? So that, I guess, sounds like so that they could bill directly.
That is also a could be. Yes, because that's infrastructure for provision, billing, and claiming. So could be.
So Jennifer, are you the point of contact on this grant of what is good and what's bad? And what's yes or what's no?
Yeah, we're working with ODE. So, but yes, I'm the applicant. OHA is the applicant. So I am the contact. I would encourage all of you again, please fill out that survey. Put all these things in there. We'll be looking through it and figuring out what the best use of funds is with OHA leadership as well. So these are great ideas. I love hearing them.
Or if you want to write something in an email, because it's easier, just send it to the both of us. That way we'll be sure to track it and log it and have it all.
Speaking of
So-
emails, let me just go ahead and get us to another slide. There you go.
And then there's a question here, another question about the grant.
Mhm.
Being about this grant, I want to clarify is from Jeanette. We are submitting this letter of intent and application, or you are. So it's Jennifer.
We are. So OHA with ODE's support is applying for this grant. So what we want from all of you is your input, because we want to use, if we're awarded, we want to use the funds in a useful way for all of you. So we want billing to increase. So please do let us know what would be helpful. And I'm sure not everything is going to get in there, but we're going to go over it, ODE, OHA. But no, you don't need to do anything other than tell us what you think, if you're willing, the funds could be used for to bolster the program.
And then we have a question about updating the OARs. So to clarify, it's the school-based health services OARs that are being updated. And so the question is, how and when can we get a rack in place to change the OAR? And who calls the rack, OHA or ODE?
Okay, so they're OHA rules, Division 410, Chapter 133. So I'm currently in the process of working out those details internally. So can I keep you posted on that one? OHA would call the RAC. So if there's a rules advisory committee, OHA would call that. Of course, I'm working very closely with, ODE, so we can get that information out to all the local agencies.
And so, yeah, just to clarify, because there was a reference to ODE's Division 15 OARs. And so
Oh, okay.
those were referenced by the school-based health services rules and by tying things in that manner. So what could potentially happen would be that the school-based health services rules wouldn't tie things to that OAR anymore. We don't need to update ours. Ours, there's not an issue with it. It's more, it was the school-based health services rules linking to that rule that prohibited the ESD billing. Charles, I see you telling me you had another question. Do you want to go ahead and read it out? Because I think I've gotten lost in all of these questions. There's a lot in here.
Sure. I was wondering if the grant could be used to experiment with alternative payment methods like value-based payments or a fixed fee schedule, or ways of acknowledging the local contribution by past expenditures. There's 3 models that are laid out in the bipartisan bill that created the grants, and could we explore any of those?
I would think we could take a look at them. I think the prior year audited cost system that we have in place right now is pretty clean, but we can definitely take a look. And I think that would fall under one of the 3 categories that we need to stay within. So
Thank you.
We can discuss that internally for sure.
Jennifer, one of the biggest barriers that I've known as long as I've been doing schools and Medicaid
Mhm,
is a workload issue.
mhm,
So if there is a way to streamline the process for all involved, where it's a universal approach by all districts that they could use, and from that, entering your data, then from there, it gets automatically into a link to, yes, this is billing, you just hit that, and everything that you've typed can do, but everybody uses the same system. I think some of the problems is we each, over the years, and have different systems that integrate, and they don't all do the same thing. So districts, because it becomes so cumbersome, it's a workload issue, and everybody already knows that ancillary service providers, they're already well overloaded right now. So in the grant, if that could be a process of looking at that process to help the providers, which I'm trying to do, because then they have time to deal and handle the needs of the student more than a paper, as they call it, Sri, I'm not a paper pusher. I'm a patient provider.
right.
And maybe somebody else on this call can explain it. I'm not a provider. I'm just one of those persons trying to link it together.
I could probably help with that. We have a program that we use for logging for Medicaid. We this year have a biller to help submit those logs and work in the background for it, which is super helpful. However, our biggest challenge or barrier that we have is the providers having the time to take what they have done and sit down and put it into the system for logging it and sending it for billing. And we're looking at a different system for next year, which is going to create a whole new tornado for me, but I'm hoping that in the long run will be better because it'll be more user friendly. However, that ability to know what system is going to be best for us to submit these bills and also communicate with synergy and ease of use for staff providers who are providing this care is the hardest challenge of becoming a district that bills Medicaid.
Joe, you have your hand up?
Yeah, thanks. Being a provider as well as an administrator across both schools and the health systems, the fundamental difference is our health service providers who go through actually probably a more intensive billing process through Medicaid in terms of claims submission and stuff like that, have capacity, meaning like they just say, oh, we're full. And then they have wait lists. And then we have like all the problems with access to care that we have in our health system. School districts do not have that luxury. Students who have an address in the catchment area are welcomed into the school setting. And if they have a specialized education need, IDEA requires school districts to not only like wait to identify them, but to proactively identify them under child find, which means the workloads are not comparable. It's like comparing apples to automobiles. It's not even the same thing. And so when we talk about workload, it's so lopsided. And providers in the medical field can actually just put strictures around that saying panel's full or sorry, billing doesn't work. And those issues are felt in a different way in terms of access to care, which is actually making it harder for schools because then those services aren't being provided anywhere but the schools. And SLP in the community has a caseload panel of like 100, like something, maybe like if they're super, just community provider. But in the schools, we're talking like several hundred, like it's a factor greater. And so like when we think about testing the administrative burden, schools are going to break every system that OHA has constructed because most of the rules are just written for doctors' offices, right? Like it's just, and that's how Medicaid looks at it. But I do think this is a space for like assertive advocacy around, yes, and like I work in behavioral health, like we're just dying on the flippin' vine.
Mhm.
Like we're 51st again for youth mental health 2 years running. Like that's not good. And it's because of stuff like this and access to care. So sorry, I usually try to stay off my soapbox, but y'all queued me up. So I'm gonna put it away. And the people who know me will be like, okay, cool. Thanks, Joe. Now we can go back to the meeting.
All right, Joe, I already started it, so you just finished what I was saying, so thank you.
Yeah. And I appreciate the input. Yep. Thank you.
Long distance high five, Shuri.
Okay. Anything else while we're here? The chat questions, I think I've addressed all of. Is there anything else anyone wants to ask while we're here?
I'm sorry, I'm still confused as to the services that are allowed with this. And I appreciate the fact that you gave the 410-133 rule, which I'm looking at right now, and I'm real used to looking at Oregon administrative rules, so this hasn't been too much of a challenge. But I do, so you're not allowing for like QMHAs and skills training? That's not allowed through this rule? And I'm confused by that, because I would think that in a school setting, when you're looking at supporting a youth with behavioral health issues, that those services would be paramount in order to support them within their school day. It's not counseling. It's the behavioral supports that they're receiving. So maybe, and I am a CCO, and LCSW and no Joe, so I understand his oratories, but I would think that maybe that would be something that the school folks, as you're responding to this, this link, would be something that you would want to ask for is, what is it that you think you actually need in order to support these kids that have these high emotional and behavioral health needs? And also, sorry, Joe, I'm doing my soapbox thing now too. But I also know, based on what I know about the schools, is that a lot of these things that the kids do are traumatizing to the staff. And Corvallis is one of my areas, and school districts, there was all kinds of articles about teachers being hurt by kids who were behaviorally dysregulated. So that might be another thing to think about, is how is it that you can support your staff as they're dealing with and doing their best to educate these kids that have these high emotional and behavioral health issues. That's
Yeah.
all.
No, that's great. Thank you for that. So we are currently operating under the rules that are in place. So the rules that are in place came about from the state plan that was in place. And our first step, again, was that state plan amendment. Let's open this up some. And now we need to take all of that and place it in the rules and have a new set of rules that carries that work forward. So we are looking at, it's categorized by services now. We are looking at what additional providers we can add as well. So thank you for that. And it is great. Like, I love that you recommended, like, say what you need in the surveys, say what you need, because, and this goes back to when Joe was talking as well, Medicaid is Medicaid, and we think Medicaid, and it's true. It's not that we don't want to be open. We absolutely do, but we need engagement, because we may get caught up in our box, our Medicaid box. So please do tell us the providers that you need in schools. Tell us what's going to help you be successful. And not just in reimbursement terms, but in the service terms as well. Because we're creating pathways to reimbursement, and we want to do so in a meaningful way.
Okay, we now have another question in the chat. Can you, oops, another one. Can we, oh my goodness, my cursor is going crazy. Can you talk about personal care services and how activities of daily living and IADL supports billing works? This was highlighted in the guidance from the federal government on page 22, the CMS guide.
So I can't right now. I can tell you that we're going to dig in, and I would love to provide information back to you on that, but I haven't dug into that piece yet.
ODE did conduct a survey where we reached out to school districts to ask about how those services were delivered in their schools, how they were documented, and who was providing them and who was providing supervision, just to get a preliminary bit of information on what it could look like. And we also have some examples from other states on how they have been doing that and billing for that. And so that's kind of so we can have a baseline, and then there'll be additional work done when the rules are updated. Any additional questions? We got to thank you to both Jennifers. See that we're be the dynamic duo. So yes, thank you, Joe.
Team Jennifer.
Yeah. So
Thanks,
okay.
everybody.
Yeah, thanks, Cherie, for your input. Okay, well, we'll stay on here in case anyone wants to hang on and ask additional questions, but you're welcome to get 15 minutes of your day back. Thank you, everybody, for participating.
Thank you all.